Go ahead. Repeat, this is the board, meeting for the Board of Health.
Oh, hold on.
Third time's a charm.
This is good.
I'm so sorry, it's been a long day.
There we go.
Welcome, everybody. This is the annual meeting of anything but the Board of Health. So, welcome. We're opening up the meeting for the Board of Health for October 22nd, 2024. We're going to go ahead and start with introductions around the room real quick.
Dave Linda, Mason County Public Health Director.
Ian Tracy, Mason County Environmental Health Manager.
Carrie Davidson, Shelton School Board.
Peggy Van Buskirk, Hospital District 2.
Randy Nevin, Mason County Commission.
Sharon Trask, Mason County Commission.
Kevin Judy, Mason County Commission.
On Zoom land.
Hi, Rachel, I'm the Swanson Health Director.
Thank you. All right, next up we have approval of the agenda. Do I have a motion to approve the agenda?
So moved.
Second.
And it's been moved and second for the approval of the agenda. All in favor signify by saying aye. Aye. Any opposed? Motion carries. Next up is the minutes.
I make a motion, we approve the minutes of July 22, 2024.
Second.
It's been moved and second for the approval of the minutes in their entirety from July 22nd, 2024. Any comments, polls? Hearing none, all in favor signify by saying aye.
Aye.
Any against? Motion carries. All right, health officer report.
And Steve couldn't make it, so I'll fill in. A couple things going on around the state. In Franklin County, they have, they're in incident command for an outbreak of H5N1, which is bird flu. And they've got, I think they have 2 people sick right now from transmission from birds to humans. So Franklin County is following that pretty closely. We don't have the same kinds of things happening here because we don't have those big, commercial poultry farms. So, but we'll still advise people who have backyard chickens to watch for signs of bird flu, and we'll put that stuff up on our website so people can know what to look for. Other things that have been going on for the health officer, he was up here, last week before last, for our ribbon cutting for the new building. Comes up, spends time with staff, working through some things as we start going into our syndemic grant, which is the our drug outreach program, syndemic grant being part of it. And Dr. Krager's working on us on how we align that money, how we spend that money, how we want to do the outreach to the community. A lot of that is around the Hep C testing and treatment work. So we're working on that. And Dr. Krager is very, very much involved in the planning processes of that work. So, and then also working on our ARNP. We were approved for ARNP last spring. We're kind of changing direction a little bit based on some feedback that we've gotten. And I think we're going to come back to the board and talk about ARNP contract rather than a staff employee. So it might be easier to contract for ARNP than it would be to put one on staff. So working on that and working with Dr. Krager to figure out what the duties would be and license comparisons, all that kind of stuff. So, but Steve's been very involved with us. So he's there anytime we need him. So we have had a number of TB case rule-outs and some other work around tuberculosis, which is surprising how much work we've done on TB in the last couple of years. Compared to my prior years here, it seems like we're working on TB all the time. Where before we might get a case a year, 2 a year, but now we're seeing more and more of it. So Dr. Krager is very much involved in those things. So I think that's about all he would have had for today.
Okay, we'll just move right on to you again anyway, though.
Okay.
So administrative
Back
report.
to me again. I talked about finances in my written reports. I'm not going to go back to that other than to say that we have our new CONCON, which is a consolidated contract coming out. We got the new draft requirements. So figure the CONCON is made up of a number of pieces. So you have the base CONCON document. It's all your wherefores and all the background stuff about dissolution and all that kind of thing. They've made a few significant changes to it. And I've sent those over to Tim Whitehead for review. one of the changes is they now have included a clawback provision, so if something's not done to their approval, then they can pull the money back, which is interesting because we bill them for reimbursement. So it's not like they're giving us the money up front for that piece, it's a reimbursement. So I'm kicking that back to DOH and through WASAFA to say this doesn't make sense. So and we've never used it before in the 20+ years we've been using CONCON. So why now and why this? So we'll be asking that question. We have the governor's budget coming out in December, and DOH has put, I could put a piece in my packet about this, for a decision package, and really only about 41 million of it would affect public health, and we'll see where that goes. I mean, the governor can put what he wants in his budget, but the legislature is in no way held to looking at that, and typically they set it aside, say thank you, and they go on with their own budget. And this is where we are coming up into a biennial budget year, so it's gonna be a long session, and I don't expect to see any results out of that until the very end of April, May time period, which for us locally, what that does is if we don't get the budgets out, the legislature doesn't settle on the budget sooner than that. Typically in biennial years they don't. There's a real crush to get everything done in June and get the contracts out the door so we have our money on July 1st. Typically that's not happened. And 2 years ago, we didn't get our contract until I think September. So, and we were told we could back bill, but we can't back bill at the county level. We can't back bill for things that we've spent money on. So, working with DOH to see if they can get a lot of that work done ahead of time so they can plug numbers in and get the contracts out the door. So we'll see how that goes. On the 5th of this next month, which is what, in 2 weeks from today, we are meeting in at CTAC. It'll be all the health directors, all the health officers. We'll be meeting with Dr. Shaw, who's the Secretary of Health, and his staff. I actually got to put the agenda together. So Dr. Melnick is the longest ranking health officer in the state, and I'm the longest ranking health director in the state now. So we got to pick the topics. So we've been working through those with DOH. That's going to be a good all-day, also let's just say a workout with DOH in the room. Kind of a let's sit down, take off the gloves, and away we go, and talk about some of the issues that are important to us around FPHS, which is our Foundational Public Health Services funding. Who gets to decide what the brackets are around it? Who gets to decide what the deliverables are? Who gets to approve? So there's going to be some big discussions on that date, especially around what happens with jurisdictions our size and smaller. Because one of the things we've found is that DOH is saying, well, you need to do this work. Well, in my county, it's so small, we don't have any of that work to do. So if you give us $150,000 to do work X, Y, Z, and we don't have any of that work, it's a waste of money. We have to send all that money back. It doesn't help our problem. So how can we take that and say, if we don't have that work in our county, how do we make that flexible so we can do the work that we do need to work in our county? So trying to get some flexibility into those pieces is going to be a big thing. And that's going to be that November 5 meeting. And then we'll be meeting with WASAC in Vancouver at the end of November in that 3-day piece down there. So we'll be working with WASAFA and then working with WASAC as well, WASAC members. And that's always a good time to sit down and listen to what WASAC has on their minds as far as the legislative agenda coming up. We really don't have any big pushes this year for our legislative agenda. So other than just keep our funding whole and things are working, let's keep moving forward. So nothing really big on that agenda for us. I did want to open this up to some discussion around the board of family planning discussion and the mobile health clinic. So I'm going to start with the mobile health clinic first. We're looking at expanding our ability to do mobile health. And I've talked about this before. Last month I went down to Texas and went to the Mobile Health Care national convention and looked at some really cool vans and buses and trucks and, you know, that did all kinds of things. Learned a lot and came back and basically put the brakes on what we're doing until we really figure out our business model and what we want to really look like. So we're working through that process. We meet every week, working on how, you know, what is it we want to do, and then how we fund that, and we have the funding for it, so I'm not concerned about that. And then what do those vehicles look like? The hospitals talked to us about the possibility of leasing. If we get a vehicle that we can do mobile health outreach, they'd be interested in leasing that vehicle from us. And I think that's a great idea. It would help pay for our costs and certainly pay for maintenance, things like that. But designing our vehicles in such a way that we can make it useful for the hospital. We had a meeting, was that last month? Last month, September, where we brought all the people who were involved in mobile clinic planning, mobile clinic outreach together in one room. And said, okay, who's doing what? And went around the room, who's doing what do they intend to do to make sure that we're not overlapping and that we're filling gaps. So we're looking at filling the gaps around some behavioral health work and around some mobile health outreach. Plus, I want to see public health out on the road doing A1C checks, blood pressure stuff, working with the senior citizen centers, working with folks to get, you know, some initial screening out on the road where we can do some handoffs to our healthcare system. So, and meet people where they are instead of trying to get people in. We were just talking earlier before the meeting started about how long it sometimes takes to get an appointment, 3 months, you know? So if we can get out there and get on the street and meet people and get them screened, then we can get them into the system with maybe not a diagnosis, but at least some data for them to start working with their provider.
Guide them in the right direction.
What's that?
Guide them in the right direction.
Absolutely. Hey buddy, your blood pressure's off the scale, so it's time for you to go see somebody about that, you know.
Like now, before you have a
Yeah,
heart attack.
exactly.
Emergency room.
So,
Yes.
we talked about it at length, and Commissioner Netherland was in the conversation around costing of vehicles and purpose of vehicles. So if we buy a single vehicle that will give us the ability to have, let's say, a 2-room vehicle where we have a mental health center in one end, and we have a health exam room in the back. The cost on that is as much as going with 2 of the smaller units, purpose-built for each of those things. So we can do a behavioral health vehicle and then a mobile health vehicle, and it's probably the better bet for us to do that. And it will give us more outreach, and we'll be able to tactically change how we do things. You know, so
I think everyone that was there was on that same page. They just thought that was the wise move. Plus, the deliverable, when it could be delivered, when it can happen.
Right.
Was a game changer between the two. One is a long ways out, the other is almost immediate.
yeah, we could get something almost immediately, or we can take a year and a half to have a custom built unit made. So I'm in the process of putting together the RF request for bids, and very tightly scoped. Now that I know what I didn't know before, I can make that a lot tighter. And we did have a request for proposals out, and I pulled those back. We'd made a couple of errors. So while I was down in Texas, I was able to go to each one of those vendors that had submitted something, said, okay, there's nothing personal, I made a mistake on my end, and we're gonna redo this, and then you'll get an opportunity to bid again. And then they're very happy to take me through all their vehicles and show me all the G-Wiz stuff. And they've got some pretty cool things happening out there. I did talk to an organization out of Pierce County that's looking to come up here and do mobile mammograms. So they're talking about us. They'll continue to talk with us about where to go, where to set up, you know, how to do the outreach, you know, where we see the gaps, and they'll be working with us on that. So that's a piece that's going to get handled from somebody on the outside, and then they will make those clinical connections with people. You know, they're just going to do screening, and then they'll make the clinical connections through our local system. So that's been a really good conversation. It's one that's going to be going on as we go down the road. So mobile health is, you know, we see it with the fire department, we see with a number of other organizations, is probably the way healthcare is going to be delivered, especially in the rural areas. It's, if we're looking at how do we keep people in their communities and still get them healthcare, it's going to be through mobile health. So, working on that piece.
So funny how you come back around to what you did originally. We used to have the doctor that went there, and now we're doing it again. I found that with boats. I had a 14-foot boat, then I got a bigger one, 27, 32. Then you never put it in the water, you go back to a 14-foot boat so you could use it again.
Right, right. So I'm thinking 20 years ago when I first started in public health, we had an RV that we used to roll around Ferry, Stevens, Pond Ray, doing WIC and family planning out of our RV. And this will give us that ability again. Once we get going down the road, we'll be able to take WIC on the road. We'll be able to take family planning on the road as well. So we'll be able to keep, I think we'll be able to keep that vehicle going pretty much full time. There's enough work to be done in Mason County across the different avenues. And frankly, public health is being called on to fill the gaps. And we're doing that in partnerships with the hospital. Our new building is an example of that, a partnership with the hospital. Friday morning, we're going to be working with Mason Matters to do more partnership work. In fact, we're going to probably be hiring a director for Mason Matters that will be separate from us and separate from the hospital. It'll be its own standalone director. So, like we used to.
Yeah, used to have that.
We used to have that, and it worked very well, and then until it didn't.
Yeah.
So we're trying to get back to a model that works. So, any questions on mobile health, mobile outreach, concerns?
How about up there in Zoom land? You got any questions? No.
Oh,
No.
especially with the tribes.
Well, I guess I do have one question. Part of the mobile, did you talk at all about like doing Suboxone or like methadone or
So,
any of those?
so we've got a methadone clinic here in town that comes in mobile every day, or 6 days a week. So we weren't going to look into doing that part of the business and let them continue to do that. So that was one of the gaps that we felt had already been pretty well filled. But I do want to bring my staff out and meet with you and see, for mobile health, how can we work with the tribes and do mobile health and cover, even more of the county that way. So,
Awesome, thanks.
and they're excited to do as well. I think, well, I'm excited. This is actually kind of been fun working on this and thinking, where are we going next? How do we, and then the unfun part, how do we fund it? But I think we've got a good handle on that.
Now, did you want to get a little deeper into the family planning discussion?
Yep, so let's talk about family planning. So part of the piece of the hospital giving us the building to use is that we would take on eventually the family planning work. So it's something that we can do within different brackets than the hospital would have to do. And I'm thinking of using the Title X guidelines, although there is no Title X money left. So Title X was a holdover from prior to Obamacare going through. So we used to use Title X a lot. That was our main funding source for family planning. And now it's really more around the managed care organizations. So Medicaid organizations, private pay, private insurance, sliding fee schedule. So as we get into the family planning discussion, that's part of what we're looking at is what is the model we're going to use to fund and run the family planning clinic. In the past, I have run family planning clinics and we've had to support it with county dollars. Will it look the same now that Obamacare is, or under the Affordable Care Act? Affordable Care Act is changing. In fact, I see there's legislation out there now to make even more changes on the family planning aspects of the Affordable Care Act.
Can we connect with others for billing, to be able to bill out?
Yeah, so billing is going to be part of it. We will be doing billing. And that's part of the great thing, that the building up there is set up to do clinic work and to do billing. So we've got all the IT in place, all of the pieces to do that, and we've got staff, I think, that will easily change gears and move into that piece. So we won't have to, I don't think we'll have to do a lot of hiring.
Into the billing and
Right, so I think we have staff that can do that. We've made some good hires that are bilingual, and that will help us as well. So that's a piece of that. But we need to really nail down the business model before I completely move forward. We're in the process of starting to outfit the clinic rooms, because we'll need clinic rooms anyway for hepatitis C testing and treatment. We're outfitting a lab. So as we're just kind of picking up the pieces as we go along, until I can get either the RNP or an assistant to Melissa and put that person in charge. You will set up the clinic. And
You'd send the labs out?
we have a couple ways of doing that. So we can send labs over to Mason Health. There's another way that we can do them mobily, and it's a company called Tasso. And I think I showed you the device, right? So Tasso's got this great device.
Pretty cool.
And it's very cool, that you put a hot pad on your shoulder, put this thing on, you put a 500 milliliter vial on it, hit the button, and it takes a blood sample, fills the vial. You send that in, and get your blood test back the next day.
Wow.
So it's very cool. Some doctors' offices are starting to use this as, when you check in, they put this on your arm, they get the blood test, and then they run it through their rapid screen, and your results are ready when you go in for your appointment. The doc's already got your stuff right there. So, and this company is gonna work with us. They're talking about giving us 50 free samples, which would be great if we did like a county employee cholesterol check. You know, come by, and work through the process and make sure we know how to use this thing and get all work all the bugs out before we try to take it into the clinic setting.
So you're saying that we'd be the guinea pigs?
We can be the guinea pigs, yeah. So, and they're,
Who's we? You got a
I'm not
mouse in your
employed.
pocket? I am.
yeah,
I was
so,
thinking you guys.
I can't remember if these guys are Eugene.
I already know where I am.
Yeah. They're either out of Eugene or out of Portland, but there's a lot of technology out there that I've been looking at that is just primed to help out Mason County. And so family planning, like I said, the business model of family planning, we're gonna get that solidified, and I should have that pretty much ready to go by the first of the year. So that next year we'll get that clinic stood up. You know, a quick segue back to the mobile clinic discussion. Working with a couple of companies, Harvard MedTech and a couple others, that when you come in for syringe exchange, you come in for those kinds of services, when you leave, you will have something on your phone that connects you to care in some way. There's a couple of different ones we're looking at, and they're looking to use Mason County as the pilot for Washington.
Should be
So,
cool.
and it's something we can use for tribal clinics. We want, the one of them, I need at least 400 people. So I'm thinking of expanding to Grays Harbor and see if they wanted to jump on with us for something. So when somebody comes in, like I said, when they leave with syringe exchange, they have something on their phone, it's gonna start connecting them with care. Because it's not something that we've had in the past.
So you'd work with our nonprofits so that they would have that, or they could contact you to
They
get
can
the
contact
information?
us, yeah, so. And then the counseling piece of it, they have hubs, but then they're also contracting with local mental health professionals. So it would go through the hub and then to a local health professional that would be assigned to a person, so. It's great technology, it's very cool.
And it's multi-language?
Yes, yes. So it's, there's lots of innovation happening out there that we can take on the road with us.
Which
And,
is so cool.
yeah, and like I said, keep the leakage, you know, from going to Kitsap, keep it from going to Thurston County, maybe get more health care done here. You know, if there's a shortage of mental health providers, well, if we can connect remotely, then people aren't having to travel to Olympia. They don't have to travel to Pierce County, because I've talked to people, the closest openings are in Pierce County. So who wants to battle I-5 to go to a counseling appointment? So we're looking to do this in a new way that connects people.
Plus you may not have the transportation.
Right, transportation is always an issue. So I think public health is poised in the next couple of months, as we do all of our background and due diligence, to this next year jump out and do some very cool. This has been a cool year this year. You know, We got a new building, we got a WIC clinic. There's some cool things happening, but I think this next year, I think we're poised to do even more out there with the community. In a way that, frankly, we used to do it 20, 25 years ago. Public health was on the road. We were that connection to the community. And then we kind of contracted inside our own building for a long time, and now it's time to go back out again. So like Commissioner was saying, it's time to get back on the 14-foot boat and get out in the lake. So that's where we're headed.
You have anything else for us, or
I think that'll do it for me.
any questions for him? Then Ian, you're up. Environmental health report.
I took it easy on everyone this month and didn't have any heavy issues, so it's just a report. If anyone has any questions on the report, I'm happy to answer those questions.
Anybody have any questions? Best one you've ever done.
So going forward, make all of them like this.
Yeah. All right, community health report.
Was Melissa able to get on? No. So, I've been talking with Melissa about some things coming up for 2025, looking at our goals and paths forward, spending more time with planning and execution of a plan in life coursework, so obesity, diabetes, all those other things that we know that kill us and we're not addressing really well. And the first part of that is I've got Jacob working on all of the data. Where are we now? What has been our trends for the past 10 years? Let's go back 10 years and then, solve for COVID in there. But look what happened leading up to that. What are our smoking rates, diabetes, obesity, all those things. And then kind of figure out what COVID did in that.
That used to be what we always talked about.
What's that?
That was the stuff we talked about in these meetings every time in the past.
Right. So he's done some initial work on smoking rates, and our smoking rates have not dropped. In fact, they're going back up again.
Really?
Yeah. So, and part of that is,
Smoking as in vaping now, or?
well, and part of it is due to vaping. So vaping has got a huge increase.
Or are they considering vaping smoking?
Yeah, tobacco use.
Okay, I was a little shocked at the other. I was thinking if
And
they're
it's
doing.
amazing to me how many people think that if you're vaping, you're not smoking.
Right,
And that doesn't
No.
equate.
right. The cigarette use by itself is also going back up again. It's starting to sneak back up. And part of it is that the state spent out all the cigarette settlement money. And that money is basically gone.
So they don't have the campaigns against.
So we don't have the campaigns. You don't see them on TV, you don't see.
Yeah.
So, the population's starting to get away from us a little bit. And we know that the population's already getting away from us. Obesity, diabetes, we're at 66% obese and overweight in Mason County. So, that
66%.
66% are obese.
Are we the highest county, or is Grace Harbor beating us?
I think Grace Harbor is leading the way,
Yeah, that's what I thought,
but we're not far behind.
yeah.
And the county health rankings, if you go to the county health rankings website, it's changed how they do it. They used to have a numerical rating, now we used to have colors. Because counties are
Nobody
complaining
wants to
about,
be called out.
yeah, they didn't want to get called out. So it's shades of green where you are on
Well,
the scale.
When I first came here, we were always battling for the bottom.
Yeah.
Remember, that's a
Yeah.
long time ago, literally. We were always right there or one above or.
Well, we're not much up now.
We're still on the bottom quartile,
Yeah.
but
But we're a little better.
we're better, yeah. So, I like to think it's because we're doing better and not that because other counties are slipping down, so.
Well, some of it is also how they rank it. So like, we don't have like a exercise place next door, but people get exercise.
Right.
And
Right, if there's no gym in town, then you're rated very low in access to,
to a facility,
The
but,
fact that we
Yeah.
had one incorporated town and a few UGAs did not help us.
right,
but now we have a Y in Shelton, so.
right. So, yeah, they change the way, the county health rankings sometimes changes the way they measure things. So the measurement changes, and that makes it very difficult to track trends over time. You have a trend going, then they change the way they measure it. Well, now,
Now, are you doing better or
Yeah.
the same or?
Right.
so,
Yeah.
Remember back in the day though, all the cancer deaths.
Yeah.
We were leading everything in
Well,
that.
we still have a lot because a lot of people come to retire in our communities. And I'm sorry, but if you live long enough, you'll probably get cancer.
Right. And
That's
that's
just,
correct, yeah.
Hello.
hey.
Yeah, it's,
Yeah.
so, and I reviewed the death certificates, and our top rates above age 75 are gonna be cancers.
Yes,
You know, it's just kind of the way it,
if
It
you
rolls.
live long enough, you'll probably get cancer.
so, Melissa's working on those things. We're getting all those indicators kind of nailed down to where we can have a baseline where we really wanna go. And so if we dumped a bunch of money into anti-smoking campaigns and it's not gaining any traction, then we need to change direction to figure out what we're doing wrong.
Going back in our old databases, you remember Gerald Apple used to do stuff in the schools?
He ran SAT.
Yeah,
Is that what it was?
program.
I just remember
Yeah.
we used to invest in some stuff with the kids.
yeah.
I haven't heard of any investment we're doing with the kids in a long time.
Well, Ben's out there working with the kids. So
Big
we do-
Latino
Ben.
Substance Use Summit coming up here,
Yeah.
so, in a couple weeks.
And Jeff Becky's doing a lot with Shelton,
Right.
and I think it's mainly just technical. Well, no. Anyway,
But Ben's got a lot of that work going on
Yeah.
that he's working with Turning Point, Youth Connection and others. So, so we're just gonna start measuring that, making sure that you know,
That
what we
it's
spend makes a
actually
difference.
working. Yeah.
Anything further for community health report?
I think that's gonna be pretty good for us.
That brings us up to other business and board discussions. Is there anything in the board, especially our newest member? One of the things I want you to remember is you direct this ship. If you have something you'd like to see, something you'd like to discuss, just let us know and we will get it on the agenda. We will make it happen. That's what this is all about. And we are so excited. You know, I know you're thinking to yourself, why would that? We've been trying for a long time to get the tribes on, and you stepping up is huge for us, and we're very, very appreciative, and we definitely want to be able to help you however we can, so please don't hesitate to say something and let us move in the direction where we can benefit your community.
Okay, thank you.
And you went to the Board of Health training, right?
I did.
Excellent.
Very useful. Met some people, but I really, really enjoyed the training.
Good, and Darren Moody went as well. So, in fact, I saw him at Oyster Fest when we talked about what he learned at the Board of
So
Health training.
how often do they have those trainings?
I'm gonna say twice a year. So, I think they will probably have one in the spring because we got a lot of new electeds that are gonna, pop onto boards of health here in January. So
make
I'm hoping that DOH will put on
Yeah,
another
make
class.
sure you get that info out, because I couldn't go to the last one. It was not
Right.
a convenient time.
Sounds
Yeah.
like a,
I think I'll be teaching at the next one, is what they've asked me to do. so.
okay, we'll skip that one, we'll do the next one.
So,
Any other board comments or reports or anything, basically in the way of old business you'd like to talk about? I'm seeing none. All right, then, public comments. I see no public. Is there any public want to comment? Hearing none, I will entertain a motion to adjourn.
So move.
second.
It's moved and seconded, we adjourn. Hearing no objection, we are adjourned. Thank you, everybody.
You guys.
See ya.
Bye.
Welcome.